Welcome back to the third and last part of this recorded lecture. I changed my AI voice again. I have some disclosure first because I have been a speaker for a pharmaceuticals product, but this slide and content are purely my own creation, unrelated to company slide. I will use Thai Vaccine Guideline 2026 and CDC recommendation as the references. CDC usually update quite real-time, but due to government issue, things may slow down a bit. This is what the Thai guideline look like. Green box indicates generally recommend, while yellow and purple are conditional. The recommendation are based on age range. This is the CDC's table. Similar structure, but please note that yellow color are the generally recommended ones. You can easily read through all the recommended vaccines by yourself. In this lecture, I will talk about 3 vaccines to make you see some principle and aspects. The first one is influenza, the most straightforward ones. Recommend for all age annually. One of the major points I want you to realize is that vaccination is more than infection prevention. This data is one from many cohorts that demonstrate the same thing. People who got influenza vaccinated will have lower rates of cardiovascular events. Because these infection causes systemic inflammation, the inflammation lead to plaque rupture and thrombosis. Thus, prevent infection can prevent a portion of vascular events. You will also see in some conditions like COPD that influenza vaccine is one of the most effective interventions that reduce mortality in COPD patients. Next issue is that there are very few contraindications of vaccines. For influenza vaccine, the only real precaution is a history of Guillain-Barré syndrome following previous flu vaccination. One misconception is the egg allergy. While some types of influenza vaccine are egg-based, there are very minimal component of egg in the vaccine, which has been proven in patients with severe egg allergy that egg-based influenza vaccine can be given safely. The next issue is vaccine efficacy. There are 2 main types of influenza vaccine, the standard dose and high dose. The high-dose vaccine contains 4 times the amount of antigen and claimed to be 24% higher in efficacy. While this figure is true, what does the 24 really mean? Take some time to think for yourself. What would this look like to you? This is the meaning of 24%. This data is from the actual study. People receiving standard dose vaccine have 1.9% chance of infection. High-dose group has 1.4%, which is about 25% lower, meaning that the magnitude of vaccine efficacy depends on baseline risk among standard group. Another important point is the outcome you choose to look at. If you look at hospitalization or influenza pneumonia, the difference becomes less apparent. So the high dose still have greater benefit, but you have to understand the meaning of 24% when used in real practice. Second vaccine I'm going to talk about is pneumococcal vaccine. Major difference from influenza is that you can see many numbers in vaccine name. And also there are 2 acronyms, PCV and PPSV. Let's go back to the organism. We are dealing with Streptococcus pneumoniae, a gram-positive bacteria that has thick polysaccharide capsule as their virulence factor. Thus, pneumococcal polysaccharide vaccine is developed to target this bacteria armor. Polysaccharide is, however, a glycoprotein with weak immunogenicity because it does not activate T cell. So scientists conjugate the antigen with diphtheria carrier protein, which is highly immunogenic and activate memory T cell. The result? PCV, pneumococcal conjugated vaccine, was produced and become the main vaccine for this bacteria. Another aspect of pneumococcal vaccine is the number of serotypes included. Not all serotypes are equally important. Serotype 3, 6b, 19A, and 23F are the most important pathogens in Thailand. So when we decide to give a vaccine, we want to choose a vaccine that contains those serotypes first. The PCV15, PCV20, and PPSV23 contain all of the important serotypes and are the mainstay of Thailand pneumococcal vaccine. Soon, there will be PCV21 come out, but this 21 serotype vaccine is not 20 plus 1. It was designed to contain additional serotypes as a complement to existing vaccine regimens instead of replacing them. Before PCV20, we used to have a regimen to start with PCV13 or PCV15 to build memory T cell first. Then we follow with PPSV23 to produce broader coverage. But PCV20 alone can provide both long-term and broad coverage of immune, making the regimen very simple. The last vaccine I'm going to talk about is varicella zoster. Recall that this infection began as chickenpox, usually in children. The virus then resides within our nerve root and later in life reactivates as shingles. So different vaccines were developed to prevent primary infection, the varicella vaccine, and to prevent reactivation, the zoster vaccine. Since varicella vaccine is created to prevent primary infection, people who should get the vaccine are those who never have chickenpox. Immunologic study in 2014 found that almost 100% of older people in Thailand already got infected, irrespective of their memory of infection. Thus, varicella vaccine is not indicated in Thai older adults, at least for now. Likewise, zoster vaccine can be given to all older adults without the need to ask or check if they have had chickenpox or not. There are two types of zoster vaccine. The older one is live zoster vaccine. Being a live vaccine, meaning that it has important contraindication, that is, not to give to an immunocompromised patient. In older people, immunocompromised are mainly those who took immunosuppressant and chemotherapy. However, there is a newer type of vaccine, the recombinant zoster vaccine. Goes by the trade name Shingrix. This vaccine can be given to immunocompromised hosts and higher immunogenic than the old ones. So the live vaccine has been removed from the market in USA. The three vaccines I have talked about is to guide you about how we choose the vaccine based on their immunogenicity, efficacy, and also precautions. There are one more aspect important when advice about vaccine, that is the cost. Because most of these vaccines are not subsidized by Thai healthcare scheme, familiarity with the price is an important issue when discussed with your patient. We have come to the end. I have a mnemonic for you. ASCVD. This will help you remember the issues you should cover when advising on screening and prevention. A for atherosclerotic risk, atrial fibrillation, and abdominal aortic aneurysm. S for geriatric syndromes. C for cancer screening. V for vaccine. And D for DEXA scan, aka bone mineral density. If we break down into actions, you can see that prevention and promotion are not only about the investigations, but include history taking. Physical examination also. And what we discussed in this lecture are just a small aspect of the whole prevention-promotion checklist. But the same principle applies to all topics. The main objective of my lecture today is to guide you on these principles. For you to take care of actual patient, actually, you can just read and follow the guideline of where you work. That's totally fine and will make you an adequate doctor. But if you understand the logic and evidences behind the recommendations, you will be able to form an individual plan that fit the need of your patient and context. So I encourage that when you study any guideline, try to go beyond the recommendation. Try to understand the reasons and shape your own practice.
We still have a few questions left in Google Forms and one assignment to help you develop deeper understanding. If you have any question, please ask in the forms. Thank you for learning. Have a nice journey.